Welcome everyone to the third portion of our first QA Forum of 2025. I'm Dr. Michael Novick, the Director of Education and Associate Director of Quality Assurance for vRad. Today we'll be reviewing some body cases from our QA archives. A bit of bookkeeping first. Here is our accreditation statement. And here are the learning objectives for this lecture. Our first patient is a 53-year-old man with elevated liver function tests. These are images from a right upper quadrant ultrasound. Next, we'll scroll through these axial images from a contrast-enhanced CT scan of the abdomen and pelvis. Here are the coronal images from the same study. The patient subsequently underwent an MRI examination. Here are the axial T2 weighted images from that study. And here is the coronal post-contrast sequence from the same examination. Okay, let's review the findings together on this transverse grayscale image from the ultrasound study. We have a large gallstone in the gallbladder neck. With adjacent biliary ductal dilatation. The findings are also evident on the CT scan. The large peripherally calcified gallstone in the gallbladder neck, and the adjacent biliary ductal dilatation. Once again, on this coronal image from the CT scan, we can see the large gallstone in the gallbladder neck, as well as the adjacent biliary ductal dilatation. Finally, on this axial image from the MRI, we have an ovoid focus of signal dropout in the region of the gallbladder neck, consistent with the gallstone we saw on the ultrasound and CT, with prominent adjacent biliary ductal dilatation. On this coronal image from the MRI, we can again see the gallstone in the gallbladder neck, and I think this coronal image demonstrates nicely the mass effect exerted by the gallstone on the adjacent biliary tree, resulting in the ductal dilatation. So this is a case of Maritzi Syndrome. So Maritzi Syndrome is relatively uncommon. We see it in approximately 1 in every 1,000 patients with gallstones. And it's caused by extrinsic compression of the biliary tree, usually the common hepatic or common bile duct, due to gallstones in the gallbladder or cystic duct. Patients present with all the signs and symptoms of biliary obstruction, including jaundice, cholangitis, and cholecystitis, and Maritzi syndrome can sometimes mimic other pathologies such as cholangiocarcinoma. There are several classification systems used to characterize Maritzi syndrome, with the Sendes classification being the most commonly used. Type 1 involves simple compression of the extrahepatic biliary tree. There are subtypes here, but I won't get into those in this lecture. Types 2, 3, and 4 involve various degrees of cholecystocholedochal fistulae, with the type 2 involving a third of the circumference of the common hepatic duct wall, type 3 involving 2/3 of the circumference, and type 4 involving the entire circumference of the common hepatic duct wall. Patients with Maritzi syndrome type 5 have advanced to a cholecystoenteric fistula, and it's not surprising that a percentage of these patients present with gallstone ileus. If you're interested in some further reading on Maritzi syndrome, this is one of the excellent articles I used for this talk. Our second patient is a 48-year-old woman with abdominal pain, nausea, vomiting, and weight loss. We'll begin with the axial images from a non-contrast CT scan of the abdomen and pelvis. Here are the coronal images from the same study. Finally, the sagittal images from the same study. On this coronal image, I hope you can appreciate the subtle, irregular gastric wall thickening with areas of probable ulceration along the lesser curvature. With subtle adjacent perigastric edema. So this is a simple case of gastritis and peptic ulcer disease. It's also a rather subtle one. I wanted to show it because I feel like this is an area that is under-scrutinized by radiologists. We see quite a bit of missed pathology in the stomach because when we run the bowel, we tend to focus more on the small bowel and the colon, the appendix. But I think it's very important to include this in your search pattern, and I always advocate for people to scrutinize the stomach, particularly the gastric antrum, so we don't miss pathology like this. Our third patient is a 71-year-old woman with abdominal pain and vomiting. This is the rather impressive scout image from a CT scan of the abdomen and pelvis. Let's scroll together through these axial images from the contrast-enhanced CT scan of the abdomen and pelvis. Here are the coronal images from that study. and the sagittal images. Let's review the findings first on this axial image, where there is marked dilatation of the cecum in the left upper quadrant. The terminal ileum is decompressed, twisted, and kinked. On this coronal image, we can again appreciate the markedly dilated air-filled cecum in the left upper quadrant. And in the adjacent mesentery, the decompressed, twisted terminal ileum. The diagnosis in this case is, of course, a cecal volvulus. We could have made the diagnosis from the scout image, but I thought this case really demonstrated the anatomy very nicely. You can see as we scroll through the sagittal images, the twisting of the terminal ileum resulting in the marked cecal dilatation. Our last patient today is a 39-year-old woman with unbearable pain and a recent diagnosis of an ovarian cyst. Here first are the axial images from a contrast-enhanced CT scan of the abdomen and pelvis. Here are the coronal images from that study. And finally, the sagittal images. On this axial image at the level of the upper pelvis, there is a small amount of hyperdense free pelvic fluid. And there is dense contrast in the anterior pelvis consistent with leakage from the urinary bladder dome. Just a reminder that the correct term here is leakage and not extravasation, which is a term used only when describing the circulatory system. The coronal and sagittal reformats are actually beautiful in this case, which is why I wanted to show it. Again, we have a small amount of hyperdense free pelvic fluid. And we can clearly see the defect in the bladder dome through which the opacified urine is leaking. Again, here on this sagittal image, we can see the dense free pelvic fluid, which no one would fault you for mistaking for blood products given the history of an ovarian cyst. But once you see the open defect in the bladder dome, the diagnosis of bladder rupture becomes clear. Thank you so much for joining me for this third portion of our QA forum. Please join me for part 4, where I'll be discussing some vascular cases.